Hello, welcome everyone to this to the Sustainable Care Annual Conference. I'm Agnes Turnpenny, Research Associate at the Personal Social Services Research Unit at the University of Kent, and I'm going to be chairing this session. So our first presentation is going to be by Nina Hemmings. She's going to talk about reforming the English social care systems and some lessons from Germany. This is a joint project with Natasha Curry and Laura Schlepper. So Nina joined the Nuffield Trust as a researcher in health policy in January 2018. At the Nuffield Trust, she specializes in social care research, comparative research, and has been involved in a number of projects focusing on the NHS and social care workforce, covering issues such as immigration, professionalization, and equality and diversity. Natasha Curry joined the Nuffield Trust in 2011, and she is now leading the Trust's work on social care. She has researched and published on a range of topics, including clinical commissioning, integrated care, primary care, long-term conditions, and NHS reform. Laura joined the Nuffield Trust as a researcher in March 2018. Her key research interests include social care, children and young people, and mental health. So, Nina, please take the floor.
Great, thanks very much, Agnes, and it's a real pleasure to be joining you all today. I'm really delighted to present our research on the German long-term care system, which I conducted with my colleagues Natasha and Laura at the Nuffield Trust. So to begin with, next slide, please. So to begin with, I know that this Circle conference draws a wide international audience, some of whom might not be familiar with the care system in England. So to set the scene, I thought I would recap some of the most critical challenges that we face. And there are many problems with our system. Essentially, we have a liberal welfare regime in England, which means that care is subject to a means and needs test. So only people with very severe needs and the lowest means can access publicly funded care. This means that some people can face very high catastrophic costs, and in some cases might have to sell their home to afford for care. For others with moderate needs, they have to find ways to fund their own care or simply rely on friends and family to get by. There's also huge inequality area and condition. Because social care is funded by councils, the needs assessment can vary between areas, and to a large extent that's determined by the council's ability to raise funds. And of course, COVID has exacerbated this problem just when demand for services has really soared. In addition, the Treasury has a tendency to provide short-term funding in time-limited instalments. Most recently for COVID support, this is meant to expire at the end of this month. And this kind of uncertainty makes it very difficult for the sector to plan ahead in the short term, let alone the long term. And at a national level, by 2030, the funding gap is projected to be around £6 billion, just to meet the projected increase in need. And as a result of these funding shortages provided, and in order to top them up, some charge self-funders, sometimes up to 40% more than those who get help from their council. On top of all of this, we have chronic workforce shortages, and there's a heavy onus on unpaid care to fill the gaps. Please. So this all begs the question, why haven't we seen wholesale reform yet? There have been many promises over the years by politicians, dating back to 22 years ago when the Royal Commission called for reform. And while their report triggered the introduction of free personal care in Scotland, there was no such traction in England, and this has been the case despite sustained pressure from select committees, independent inquiries, the media and the public. And yet here we are in 2021, still awaiting a white paper. So it was in this context that my colleagues and I turned to other countries to uncover learning to help inform the design of much needed reform in England. Next slide, please. So that begs the question, why Germany? Well, it's an advanced economy with very similar challenging demographics. Both our populations are aging and shrinking, and Germany have a similar, if slightly starker, dependency ratio, where by 2050, for every 10 working age adults, 6 adults will be aged over 65. And of course, social care is more than just about the care needs specifically, but demographics have implications for how we fund and deliver care too. And Germany are an example of a country which have managed to undergo radical reform, going from a means-tested system to one based on social insurance in 1995. Next slide, please. And you can see that since then, social care recipients as a proportion of the general population have increased, whereas in England, as you can see in this chart, we're facing the reverse trend. Next slide, please. So England's still in a small club of developed nations that hasn't yet grappled with the thorny issue of social care, and I'd like to talk now about how Germany managed to introduce a social insurance system and the principles which lie at the heart of it, which are relevant to our specific circumstances. Next slide, please. And to begin, a quick note on methods. We essentially conducted a literature review and interviews with key stakeholders in Germany, including policymakers, academics, politicians, and not-for-profit organisations. Next slide, please. So a key question is how Germany managed to achieve reform, and the context in Germany is very illuminating in terms of drivers of change. All these factors are important. There are many of these in England, apart from two critical ones, and these are a history of cross-party cooperation and strong leadership. And unlike with our quite adversarial Westminster-style politics, in Germany they're obviously used to building coalition governments and making compromises, and Norbert Blum, who was the leader of the ruling CDU party at the time, was a catalyst for change in a very determined. He set up a grand coalition to develop proposals which included government, providers, employers, trade unions and the third sector, and compromises were made in order to make reform more acceptable, such as trading off one day's national holiday to appease employers. And it's important to note that reunification at the time was also a key factor which triggered political and economic upheaval, and the costs of reunification put even greater pressure on their local authorities' funding. And at the time of our research in 2019, we did wonder whether Brexit in England might prove to be a similar trigger. And now, 2 years later, there's a question of whether COVID might prove to have a similar effect in hopefully opening up opportunity for change in England, but that's yet to be seen. Next slide, please. So moving on to the key principles, and as a system which was designed to provide a universal minimum level of benefits, along with payments by individuals at the point of access, Germany sought to balance their traditional social policy with an emphasis on individual responsibility. And a number of key principles lie at the heart of their system and which provided the building blocks which they've since adjusted over time. And I won't go into too much depth on these, but the key ones really to note are pooling risk, with all employees paying in and these contributions being shared with their employer. And social insurance was obviously a natural choice for Germany, given the strong tradition in their welfare state and the fact that that infrastructure already existed for their healthcare system. Intergenerational fairness, with retirees contributing, as well as adults without children, and that's a very specific dimension of fairness, which is unique to Germany. Transparency in terms of social insurance being super visible on people's pay slips, as well as being strictly ring-fenced, which we heard helped with public trust. There's consistency in who can access support, so no matter your age, your location, means, your condition or circumstances, for example, if you live with a carer, that national eligibility criteria ensures consistency in accessing support. And in terms of clarity of benefits, to the German public, it's more clear what you put in and what you get out. And benefits can be a mix of cash in kind or a combination. So keeping these in mind, I'd now like to consider a few different elements of the German system in turn and how their government approached these, starting with funding and sustainability. Next slide, please. So you can see that the principles of risk pooling and social solidarity are baked into the design of the funding system in terms of who's required to pay in and how much. And everyone contributes either through their salary, their pension, or unemployment insurance. And contributions haven't remained static, but over time, and these have always been matched with clear and visible expansions in benefits, which help make the increases more palatable to the public. However, as more people in need of care have received benefits, the system started to see its highest deficits in 2017, and premiums had to be increased further. As this, costs for user contributions have also risen over time as there's no cap. So to try and address this, the German government have tried a number of different things to contain costs. They tried introducing a subsidised private supplementary insurance scheme in 2013, So far, that's been quite unsuccessful with very low take-up. They introduced a Federal Reserve Fund, which receives 0.1% of the annual LTCI contribution income. That's intended to last for 20 years and meant to kick in from 2035 onwards. There's also live discussions regarding the introduction of a cap on user contributions, specifically for residential care, and it's likely that that debate around mandatory private insurance will re-emerge at some point. I think there are still quite big uncertainties about the long-term future sustainability of the system, and in the face of rising costs, Germany is still considering where those public, private, and market responsibilities should lie. Next slide, please. So the next element I'd like to consider is consistent eligibility and benefits. And as I mentioned, Germany has a national eligibility framework, which has 5 different care levels, and this helps to determine clear and consistent monthly benefits for people. And we heard this has been critical in securing high public support. It's understandable. There are no seemingly arbitrary distinctions as to whether your needs arise from dementia or a physical need, for example. And a really interesting feature here is the option to have benefits in kind, in cash, or as a mix, which I'll return to later. But it's important to note that benefits aren't comprehensive. People still have to contribute. So, for example, those who are in care homes still pay hotel fees totaling up to €21,000 a year. That's still £10,000 to £15,000 less than the average annual care home costs in England, however. Next slide, please. And looking more closely at cash benefits, these are a pivotal feature of long-term care in Germany, and they were designed to support autonomy, which is one of the key legal principles on which the whole system was designed around. They're paid to the person in need of care, who can then do what they wish with it. They're less than half the value of in-kind benefits, but despite this are really popular, with half of all long-term care insurance beneficiaries choosing them, particularly those who receive care at home, which indicates quite a strong preference for family care. And we heard that there was an assumption by the German government that cash benefits would reduce total spending, as they were seen as a cheaper alternative to professional services. But we weren't able to find strong evidence either way as to whether these cash benefits do save money or actually whether offering them induces demand. We also heard that regulation was very light touch, and so there are some considerations here for England, particularly around personal budgets, around the extent to which cash for care or cash benefits actually might reproduce inequalities in informal care, and also their potential association with a grey market in care. Next slide, please. So the next element I'd like to consider is workforce, and we heard that similarly to England, the workforce was the most acute challenge, with all regions in Germany facing shortages. And despite most staff holding 1 to 3 years of training, care work just still isn't seen as a desirable profession. And the German government passed a reform in 2019 to try and fund 13,000 new posts in care homes and abolish fees for nurse training to try and incentivise take-up. They've set up a working group which includes the health and long-term care insurance funds, providers and ministries who are looking at improving wages through a new pay framework and also international recruitment strategies, which include initiatives like setting up German care schools abroad in places like Kosovo. Suffice to say that the learning here, I think, is that England needs to have a really clear workforce strategy for the long term. We haven't had one for over a decade, and I think we also need an immigration system that helps rather than hinders and which recognises the skill of workers. Next slide, please. And this brings me onto the last element of the system I'd like to look at today, which is informal carers, and which my fellow co-presenters will be able to shed much more light on. But what we lack in England, I think, is an honest debate about where that line of responsibility is drawn, with informal care in England feeling much more like its expectation. Reliance on it seems to be much more by default than design, whereas in Germany, it feels much more explicit in their legal principles and their norms. So, for example, adult children in Germany are obligated to pay for their older parents' care needs. And we heard that the sustainability of informal care in Germany was getting a lot of media attention. To try and achieve its aim of greater home care, the German government is trying to actively support carers through dedicated employment leave and various social security support. And it seems that Germany have done much better in recognising that reliance on carers will continue in the future, and they seem to be taking action which suggests they recognise caring isn't a free good. Please. So to return again to the principles, could they work in England? Next slide, please. And I'd like to pose these for discussion, really. I think that some of these principles, such as risk pooling and consistent eligibility and benefits, could translate to the situation here in England. Others, such as intergenerational fairness, would need much more tweaking in light of the debates here around home ownership. And in terms of clarity of offer, where would we want to draw that line in terms of what state support is on the table, and how limited or how expansive would we want to be in setting out a new social care system? Next slide, please. And so I'd like to end by considering our prospects for reform. Social care is a central pillar of the welfare system in Germany, and yet it's been described by Sir Andrew Dilnot as the one aspect of our welfare system that we forgot to design for in England. And COVID's obviously been a challenging time for social care, but it has thrust it into the spotlight, and it's now experiencing a prominence in public and political debate that hasn't happened before. Yet we're still waiting to see a plan from government, and the latest from the Prime Minister was last year, where he hinted that potentially some kind of risk pooling might be on the table. I think that reform will need to be all-encompassing and a complete upheaval that will provide a step change in the working conditions of social care staff. There needs to be much needed support and recognition of unpaid carers and stability for providers. And I think the multi-year spending review may now be an opportunity to create cooperation for change and to drive through reform. And Germany's experience shows that this social care reform can be achieved even in the most unthinkable political and economic circumstances if the will exists to achieve it. Thank you.
Thank you very much, Nina. This was a really interesting presentation. So now from England and Germany, we go to Australia, and our next presenter is Cathy Thomson. Cathy is a research fellow at the Social Policy Research Centre, the University of South Wales, Sydney. Cathy has been involved in academic and applied research and programme evaluations based on mixed methods and quasi-experimental design for over 20 years. She specializes in research on the characteristics and processes of service systems that assist or prevent older people and their carers and other vulnerable population groups accessing services and resources that support health and well-being. Cathy completed her PhD in 2019. Today, her talk is about estimating the direct cost of care for carers in Australia. So, Cathy, please.
Thanks. Before I start my talk, I'd like to acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land, and pay my respects to elders both past and present. And I'd also like to thank the organisers of the conference for providing this opportunity for me to participate from Australia. I know it's been a lot of additional work and through a very difficult time. So my paper draws on my PhD, which as I said, I completed just over a year ago. Next slide, please. So in the paper, I'll first briefly talk about the background to the research and then outline the aims and describe the analytical framework that I developed and applied to the data analysis and to frame the findings. Next, I'll talk about my method, which contained both a qualitative and quantitative component, and then I'll outline the key findings, both in terms of types of costs, strategies to manage costs, the estimated costs, and then to finish, I'll discuss the implications of the findings for sustainable care. Next slide, please. Care has become a central social policy issue in Australia and internationally, and this is due to the intersection of demographic and policy changes, which I'm sure the audience are well aware of. So things like increasing labour market participation of women, the move away from institutional care to care in the community, and most importantly, the ageing of the population. And in the time of COVID-19, carers have become even more essential. In Australia, in November 2020, the Australian Bureau of Statistics estimated that around 1 in 6 or 16% of Australians aged 18 years and over reported providing unpaid care. And since March 2020, 1 in 4, that's 25%, of people who provided unpaid care had difficulty providing that care due to COVID. The economic contribution of carers is substantial. In Australia, in 2020, the replacement cost for carers is estimated to be just under $78 billion. So that is the amount required to buy the equivalent amount of care from formal services. However, this contribution often goes unrecognised, with carers in Australia sometimes being blamed for contributing to the explosion of welfare payments. But we know that the support provided by carers is crucial to enabling frail older people and those with disabilities to remain at home. We recently had a Royal Commission into the aged care, and the report noted that carers are a critical element of the care system, and the value of informal carers to the sustainability of the aged care system is difficult to overstate. Next slide, please. So many carers gain a sense of satisfaction from caring, but it also comes at a cost, both direct and indirect costs. Direct costs for carers are the monetary costs or the additional expenditure arising from support and assistance they provide. For example, carers paying for respite services. The indirect or opportunity costs of care are the economic value of activities foregone as a result of providing care. For example, spending time in caring rather than participating in employment or education. A substantial literature exists on the indirect or opportunity costs, but the full range of direct costs haven't been comprehensively documented in Australia. And internationally, there has been some research on direct costs, particularly in the UK and in Canada, and they provide useful insights and frameworks, but the research doesn't adequately examine the different types of care costs as distinct from the disability costs. So my study set out to examine how the direct carer costs are defined and identified in both the literature and by carers themselves, to estimate these costs and then to investigate how carers met these costs. Next slide, please. So when thinking about the direct carer costs, it's important to recognise that the relationship between disability need and carer needs and the costs associated with meeting these needs. So these direct costs can be met in different ways. They can be met, say for disability costs, they can be met by the person with a disability, they can be met by the carer, service provider or government, or they can remain unmet. And research shows that in many cases, if the carer is present, then the costs associated with extra costs of disability are either partly or fully subsidised by the carer. And the research also found that carers incur extra costs specific to their needs when they're providing support. To distinguish between the costs of care and those associated with disability, I developed a framework that takes account of this complex and interdependent nature of the relationship between disability and care across and within households. So the figure on the left in this study shows that the direct carer cost consists of two components. The first component is the cost of disability that is subsidised or met by the carer, which is a subset of the larger disability costs. And then a second component, which is the additional direct carer costs incurred and paid for by the carer related to their specific care situation. It's also important to note that disability and care needs and the monetary costs associated with meeting these needs at both the individual and the household levels exist within relationships situated in the broader social and political context, and that's displayed in the figure on the right. So the identification and interpretation of needs and the associated costs occur within this context of normative frameworks of responsibility and obligation at an individual level, within relationships, but also influenced by the prevailing ideologies and social norms at the societal level and also welfare state policies. Next slide, please. So my study, I used a mixed method approach. So I had a qualitative component, which was based on 37 in-depth interviews with carers, and that was to explore the nature of the relationship between disability and care costs, and how decisions are made about distributing these costs. And then the quantitative component was based on the analysis of national data from the Household Income and Labour Dynamics in Australia survey, using a standard living approach. Next slide, please. So in the qualitative data, carers talked often about different types of costs. One of the most common types of costs were recurrent costs, which involved expenditure on items such as food and clothing or petrol that are required on a regular basis. And that you can see that in the first quote, where they're talking about how before they took on care, they used to buy bulk groceries. Now they're just sort of going from week to week, and it's very difficult for them to maintain those costs. Another common cost was one-off capital costs, such as paying for home modifications or washing machines, as the second quote illustrates. And then the carers also did talk about these, and those additional costs could be considered disability-related costs, which are as outlined in the framework, and they may be partly or fully paid for by the carer, or they could be paid for by the care receiver. And as illustrated in the last quote, carers also incurred specific costs related to their caring role. Next slide, please. Carers used a number of strategies to manage these costs. These included deferring spending, often things that are dealing with their own health needs, not going on holidays, reducing their leisure activities, or running down their savings to manage the costs. Also, carers reduced spending on things such as respite care. As the first quote illustrates, the carer had to pay for respite services to go on a holiday. However, due to the high costs, she elected to reduce the cost of the holiday, take her husband with her, which then meant she didn't get a proper break from her caring role. Carers' decisions about how to manage costs and to subsidise the cost of disability for the care receiver were often motivated by notions of love and reciprocity, and the desire to increase the standard of living of the care receiver for the remainder of their life, as evident in the second quote. Next slide, please. The quantitative component was designed to estimate the direct care costs. So in this component, I use multivariate analysis to estimate the differences in standard of living outcomes for different households after controlling for income and other factors. It is based on an assumption that households with different needs require different levels of income to achieve the same standard of living, and the difference in the income required for the households with different characteristics is used to estimate these costs. The approach has been previously applied to estimating the direct cost of disability without taking account of the relationship between disability and care. And I don't have time to go into the details of the analysis, so I just wanted to give you a brief overview of the main results. So the analysis found that a statistically significant negative relationship between standard of living and the presence of a person with a disability and/or the presence of a carer in a household. The analysis also showed that there are specific direct carer costs separate from the disability-related costs as outlined in the framework. The analysis showed that the average direct carer cost can be substantial and can be between $8,000 or can be around $9,000 a year. The analysis also examined if the estimates of disability-related costs were influenced when controlling for the presence of a carer and other variables known to influence the standard of living. And what I found was that the estimated cost of disability dropped by $2,000 per year when the presence of a carer was accounted for in the regression, suggesting that carers do subsidise disability-related costs. Next slide, please. So overall, many of the carers in the study and the carers in the world face a very uncertain future. For one of the carers who had left full-time work after 17 years because she couldn't manage her husband's increasing needs, together with her employee reducing her hours worked, commented, "If something should happen, If it happens this year, well, the government services would reasonably expect me to get back into the workforce. But who's going to employ a 55-year-old with no skills, no qualifications? If he lasts another 5 or 10 years, I'll be, I'll be 60, 65, not going to be able to get back into the workforce at 65. So it's really hard to sort of really plan for the future of that happy retiree couple. In the sunset sort of isn't for us. It isn't going to happen for us. Next slide, please. So in summary, the types and amounts and the impact of direct carer costs are diverse. It's clear that carers often subsidise disability-related costs, at times unconsciously, when the primary aim is increasing the care receiver's well-being and standard of living, and that carers incurred specific costs related to and as a consequence of their caring activities. It's often difficult for carers to distinguish between disability-related costs and direct costs of care, and during the interview it was often the first time that they'd really thought about it. The carers use various strategies to manage these costs, such as deferring expenditure on things that they deemed unnecessary, such as holiday and leisure, and expenditure on their own needs. Many of the carers in the study faced a trajectory of escalating expenditure and uncertain financial future. And in terms of the sustainability of care and the implications of my study, I think Toronto's concept of democratic caring, or caring with, which focuses on how the needs and activities associated with care should be undertaken in a way that is consistent with the democratic principles. I think Toronto's 2013 concept of democratic caring, or caring with, which focuses on how the needs and activities associated with care should be undertaken in a way that is consistent with the democratic principles of justice, equality and freedom for all citizens. It encompasses the goal that no one goes without care. Also, everyone should be involved in the decisions and the negotiations about assigning caregiving responsibilities. Toronto's care-centred democracy provides a possible framework to rethink the allocation of care responsibilities and the cost incurred across family, society and the state. Sustainable care can only be achieved through informed debate about the needs to more equitably distribute the direct care costs if we are to understand the challenges of current carers and to develop policies to support future care needs. Next slide, please. I just wanted to acknowledge the support that I received through my PhD. Thank you.
Thank you very much, Cathy. And now still staying with informal carers, but moving to Finland and England. Our third and final presentation is by Minna Zechner. Minna is Associate Professor at the University of Lapland in Finland. Her research interests include care of older persons, welfare state change, migration, transnationalism, qualitative and comparative research. Today, she's going to talk about her joint research with Fiona Morgan from the University of Wolverhampton and going to look at the comparative analysis of familialism in cash for care schemes in Finland and England. Minna, please, the floor is yours.
Thank you. I have to say that even though being online in an online conference is not the same as being at present, but this is anyway very nice to hear and discuss these care-related issues. So my title is Uncovering Familialism, Cash for Care Schemes in England and in Finland. And this is written, like Agnes said, with Fiona Morgan from the University of Wolverhampton. So since, maybe next slide, please. Since care continues to be predominantly provided by informal carers, the long-term care policy tools that address informal care and the implications of those policies for older adults in need of care and their carers, these, both of them must be in the focus of analysis. So this study compares the care policy options provided in 2 states, Finland and England. And these policies are the ones that support adults aged 65 and over who have social care needs and those caring for them on account of a pre-existing relationship as a relative or spouse or partner and so forth. So we analyze similar policy tools in different welfare state contexts. In England, the state plays a significant but rather residual role in targeting public support at citizens on low incomes through operating a safety net system. Finland, on the other hand, was considered, at least in the 90s, as part of the Nordic welfare states. There was an advanced system of safeguarding citizens' right to social care based on national legislation and providing tax-funded, needs-based and locally implemented public service provision via municipalities. And there still is this kind of a system, but difficult to say whether it's an advanced system anymore, since austerity politics and marketization of care services have been eroding this status. Next slide, please. So there are generally three key types of policy tools that address citizens' financial and support needs, which arise from requiring or providing care. So there are these social security benefits, allowances and insurances that compensate the cost of associated to care. And then there are social care services, which actually provide direct physical assistance to older people and their carers, or older adults. And then there are these employment-related measures, care leaves or flexible working arrangements. And this study focuses on the first ones and look beyond the surface of the care policy tools and cover the implicit nuances of cash for care schemes in practice. We assess the extent to which such policy tools affect the caring responsibilities of families by defamiliarization, familialisation, or even refamiliarization. Next slide, please. Defamiliarization describes the extent to which states enable individuals to reduce their dependency on family care by providing alternative sources of support. This can be achieved by replacing informal care with the provision of formal care services, either from the public, not-for-profit or for-profit sectors. So there's defamiliarization through the market, when cash transfers, vouchers, or tax benefits are offered by the state to individuals to buy services in the wider care market, or when state funds market-based service provision. Then there's defamiliarization through public provision, when there are public services at place provided by the state. Then there's familialism, which considers whether families are expected to provide care as part of their familial obligations, either formally through state legal intervention or implicitly through policy absences, or if states recognize the need to provide informal care with financial support or services to sustain their caring role. Unsupported familialism or familialism by default means that there are no publicly supported alternatives to informal care. Then there's implicit familialism, means that policies neither actively support the caring function of the family nor offer defamiliarization, meaning services. Prescribed familialism gives families explicit responsibility through laws to care their family members without specific support from the state. So not to make things too simple, there's also supported familialism, where states recognize and attempt to address some of the needs of family carers through the provision of policies to help maintain their care responsibilities. And optional familialism is present when families can potentially choose whether or not to provide the care themselves or rely on formal care services instead. So these are very close to defamiliarization as well. And then finally, refamiliarization refers to public discovery, sort of rediscovery of informal care to reduce public spending on care. Next slide, please. So in this table, we have collected these different definitions and where they have been used. So you can see that it's a sort of a messy and overlapping jungle of concepts, but I only focus on some of these. So next slide, please. So this is a table about cash for care schemes in England and in Finland. The cash for care schemes under analysis fall under the following categories of policy tools: Social Security cash benefits and tax allowances, cash and equivalent support provided by municipalities. I think in England they use the local councils rather than municipalities, but we decided to use the word municipalities. And instead of a macro level cross-national comparisons of cash for care schemes, which are more common studies on cash for care, we did a more nuanced meso-level analysis. So we considered whether the cash for care schemes look the same and are the same, look the same but are different, look different but are the same, or look different and are different. So here, because we don't have that much time, I'll take just a brief look at carers allowance in England and informal care allowance in Finland, which are here circulated in yellow. So next slide, please. Explicit schemes offer cash payments to cover the cost of care-related provision and are generally regulated. So we divided these schemes into explicit and implicit. In England, an explicit schemes are personal budgets and direct payments for adults and carers provided by municipalities and the Social Security benefit carers allowance. And in Finland, the informal care allowance provided by Finnish municipalities. Sort of implicit cash for care schemes offer cash or tax benefits that cover associated care costs, such as assistive devices or home renovations, or are unregulated, allowing for unprescribed use. In England, we sort of titled the implicit ones as attendance allowance, and in Finland, care allowance for pensioners and tax credit for domestic help. Various aspects of each scheme were incorporated into this analysis to understand the outcomes. We looked at the eligibility, the generosity levels, and state regulation of the scheme. And of course, we also looked at some outcomes and the wider policy settings. So I will take one example per country: the carers allowance in England, informal and informal care allowance in Finland. Next slide, please. So the carers allowance in England, it's accessed via the Social Security system. It looks like a form of wage replacement intended to compensate carers financially for the income from paid employment that is lost due to caregiving. And this could be considered as a form of supported familialism from the outset. Carers allowance can be paid to informal carers no matter what their relationship or living arrangement with the person they care for are, as long as they provide a minimum of 35 hours of care every week to someone who is eligible to receive a disability allowance such as attendance allowance. Carers allowance claimants are subjected to an income test which excludes any individual earnings more than £128 per week, which is lower than at the risk of poverty threshold for one-person household. This was £152 per week. It means that this financial support can only be described as symbolically recognizing informal care, but offers no wage replacement or meaningful payment to compensate the caring role, and actually actively restricts carers' earning capacity. So we conclude that carers' allowance represents rather a form of implicit familialism. Informal carers are either forced to forego the state support, continue to work, and rely on defamiliarization via state or market, if these are accessible or affordable. The other option, closer to implicit familialism, is to accept the support, and the carer is forced to restrict their labour market participation and income to provide care. Personal budget could be an option, but if it is a couple living together, it is not possible to formally employ a cohabiting informal carer. So there are limitations regarding cohabitation and other earnings that make the benefit not supported familialism, as it seemed at first. Next slide, please. Informal care allowance in Finland. Informal care allowance provides a combination of cash and time off for carers and replacement care services to the person being cared for during the carer's time off. It also looks from the outset as supported familialism, but when it's placed in the context of other aspects of Finnish long-term care policies, the outcome is rather different. Finnish municipalities may actually decide how many care bandings of the benefit to offer, how the bandings are defined, including how substantial the care needs are, and the frequency and the intensity of care undertaken by the carer, and the level of benefit provided for each banding. So it's a wild world out there. The only requirement is that municipalities adhere to national regulations setting out the minimum benefit, which in 2021 is 413 euros per month. So all these results a wide regional variation. Additionally, both institutional and home care provision in Finland is more strictly targeted than previously. And that means that the usage of informal care allowance has been increasing since the services are not really accessible. Finnish reforms and austerity measures are forcing individuals to undertake informal care by making the defamiliarizing options of care services less accessible, leading to a process of refamiliarization. Additionally, an estimated 20,000 informal carers, and mind that there are 5 million inhabitants in Finland. So about 20,000 informal carers provide intensive informal care without informal care allowance. And actually there's an estimation that there are about 300,000 who generally do give informal care without a support. And since this informal care allowance is budgeted by municipalities, and they have also a budget restriction, sometimes it has happened that some applicants who meet the needs test for informal care allowance are not actually receiving it. So this is needs tested, not means tested. So the decreasing availability of public services and insufficient budgeting of informal care allowance actually points towards implicit familialism, that is disguised behind the informal care allowance, which would be supported familialism, and public services defamilialism. So by creating sort of policies that look like they support, it's hidden this implicit familialism. Slide 9. Next slide, please. In order to expose the familializing or defamilializing effects of cash for care policies, and this kind of an in-depth meso-level analysis is required. And it was also useful to make the international comparison, although I was not able in this time to present it. So it looks more like these are done parallel. But the analysis showed how the members of the caring dyad can be affected differently. In England, the carer's allowance limited employment while not offering proper income for the carer. And this again affected the choices of person need of care when income levels and sources of income dictate where care is to be received. The Finnish informal care allowance relieved regional differences and outcomes that differ from the expected supported familialism. Next slide, please. Thank you.
Thank you very much, Minna. And now we are going to hear a few remarks from our discussant, Patrick Hall. Patrick is a research fellow at the Health Services Management Centre, the University of Birmingham. Patrick is a social care policy researcher with over a decade of experience in the sector with a background in local government. Before joining the Sustainable Care team, he was a fellow at the King's Fund. He also worked in policy development for the Social Care Institute for Excellence in England. So, Patrick, please.
Oh, thank you so much, Agnes, for that lovely introduction. And yeah, I would just like to say thank you, a huge thanks to all of the presenters for such interesting discussion. Although we can't be together in person, it's very exciting to bring together thinking, from around the world about this fundamentally global issue of care and caring, and which has been brought into such great focus by this COVID-19 crisis. I'm sure that we will meet again soon to discuss these issues in person. So I'll start with some reflections on each of the presentations and end with a question for each of our presenters, and perhaps we can all chip into a discussion as well. So I'll start with Nina's really in-depth presentation about the reforms in Germany. The study from our colleagues at the Nuffield Trust has been really important in contributing to our national debate in England, and in fact across the whole UK, about the direction of travel for reform in making our system more sustainable. The study shows the ways in which Germany's political system, policy system, has been able to overcome the sense of drift that's emerged in the UK systems. This sense that there are available solutions to the problems of social care, which she pointed out at the beginning of her presentation, and yet we still can't manage to find any consensus around the solutions. It shows how the establishment of long-term care reforms in Germany were built on overcoming political partisanship. In Germany, their care regime is often characterized as a conservative care regime, which emphasizes family responsibility, subsidiarity, and social solidarity, emerging from the post-war constitution built as it was on Catholic social teaching. And in the UK, we don't have such an explicit set of care values, or indeed welfare values, and that often, as Nina said it so brilliantly, that actually, our values have emerged more by default than by design. I guess the question is, how do we design it? How do we come as a political community to a consensus around the values which should underpin social care reform in the UK? And I'll come back to that. And it was followed by such a great, in-depth and rigorous presentation of findings by Cathy Thomson. Really fantastic presentation, so in-depth, and I'm really interested in this combination of methods and the richness to the findings that the combination of quantitative and qualitative analysis brings out. But Cathy's study really shows the huge financial impact of informal caring, and the ways in which informal caring can impact people's lives in such a fundamental way. One of the other things I think is in Cathy's framework is really an interesting analytic framework which she discussed there, which draws attention to the impact of normative expectations, ideologies, social norms on carers. And although there have been these kind of large changes to Australia's social care system, I'm not sure if there have been similar levels of value agreement as there have been in Germany around what the expectations for informal and family carers are. She mentions Joan Tronto's democratic caring ideal as the ideal towards which the Australian system might move. So I'd be interested to hear from her how she thinks that might happen in terms of the process politically and policy-wise. As Australia comes out of reflecting on the Royal Commission's findings recently. And finally, Minna's presentation around familialism really draws attention to the status of care policies and how they act as a social join, impacting the possibility of participation in work, in public life, and in social life, I'd argue, and how these policies to support informal care can be perceived as adequately or inadequately compensating for exclusion from these other areas of social life. The fact that these policies have a social impact which isn't immediately graspable, and that they often have an implicit meaning, is something that I've really taken away from what she presented. And the fact that they have a social impact way beyond their immediate presentation means that work such as Minna's to uncover their social meaning really is vital in democratic societies and has to be part of a much broader discussion about how to make those values explicit. So all of our presentations, I think, give us food for thought regarding the values that could underpin social care reform and move us towards sustainability. So I've got three questions for each of our, well, one question each for our presenters. For Nina, I guess I'd like to ask what a values discussion might look like in the UK. Are there common values such as those in Germany around subsidiarity, social solidarity, that we might find consensus around in perhaps a more liberal and fragmented society with fundamentally different views socially? How might this happen politically? For Cathy, could you tell us a bit about the process of implementing change in the care system in Australia? You mentioned Tronto's democratic caring ideal, so I'd be interested to hear in your reflections how we might move the political and policy process to facilitate a move towards this ideal of caring as the shared work of citizens, as Joan Tronto puts it. And for Minna, you talked a lot there about the implicit meaning of policies. I'd like to maybe turn the question around and say, is there an implicit value judgment in these concepts of defamiliarization, refamiliarization emerging from a feminist critique? So are any of these processes seen as progressive, or are they simply descriptive? So thank you.
Thank you, Patrick. So I don't know, I guess I'd like to open the discussion, everyone. I don't know how we'd like to take the questions and answers. Nina, would you like to start? No pressure. Anyone else?
Yeah, I'm happy to start, and thank you, Patrick, for some really interesting reflections and a really good question. I guess, so in terms of what a values discussion might look like in the UK, we're sort of on a bit of a back foot because, from my understanding, everyone has a different take on what social care is, and knowledge of what social care is very low to begin with among the public. So in order to have that first conversation, there needs to be much better awareness, which I think we're starting to we're starting to see progress on as a result of COVID, with social care obviously much attention in the media, and it's now jumped to the top of the political agenda, I think. But on your specific point about values such as subsidiarity, and given the differences in our welfare regimes between England and Germany, I guess we can look at some other countries in terms of how they've done this. So my immediate thought is, if we turn to Wales, I think they've done some really interesting stuff around citizen assemblies. I know that we've done that in England too, but I think, at least in Wales, there seems to be a strong culture of involving all types of stakeholders, whether that's government, providers, trade unions, I think employers, and obviously the third sector as well, and specifically people who use care. And maybe that's something that England should be focusing on now in the next stages, especially thinking about the run-up to the spending review. It feels like now is a really time to start having those conversations very openly and honestly, whether we might overcome political partisanship that you mentioned. I think that consensus and will to come together and achieve reform is there. I think it's difficult to say. I'm not sure exactly what the solution is in terms of bringing people together to find that consensus, because it's taken so long. But I think some of those core principles might provide a foundation. So risk pooling, fairness, transparency. I think these are things most people agree on and would want to see in a reformed system. And that might provide a start point for discussion.
Oh, thank you.
Do you want me to jump in about?
Okay.
Yes, Cathy?
I was going to say, do you want me to talk about democratic caring, or have you got other comments?
Yeah.
Well, I mean, I must say, I don't think Australia is moving towards democratic caring. This is my ideal, my utopia. I think, though, that we have an opportunity with the findings from the Royal Commission, which were, some of them were quite shocking, although people who are in this sector are quite familiar with them. But I think some of the, because it's such a broad brief and the findings have been quite well publicised, I think we have a chance to rethink how we're providing care, which involves carers as well as the people who are receiving that care. And I think one of the things that came out was that the Royal Commission did have a focus on carers. So they specifically said that the system is sort of underpinned by the support provided by carers, but it's also a system that is lets down the people that need the support. So that's in terms of the frail older people, and particularly in nursing homes. And it's around things that are developed based on a profit model. And I'm sure that these are not unfamiliar issues for the other presenters, where you've got something that's purely based on making a profit. It doesn't work when you're providing care, because care is about relationships, it's not about outputs. And I think that we need a system where people can have the opportunity to get the sort of care that they need, that is affordable and high quality. But carers should have the choice to provide that care at home, but also the care receivers should have the choice to not receive care from carers. So I think one of the ways to do that is it's such a catchphrase, but listening to the stories of carers and care recipients, but I think they're really telling, and I don't see how policymakers cannot be moved by some of these stories and want a system where, as they age or as their parents age or their child with a disability needs support, that you want a system where it's equitably distributed, both the costs and the impacts across society, not just women, not just people who are disadvantaged financially and have no other choice but to go into low substandard care. So I don't know. I think the Royal Commission gives us a chance to rebuild. Whether or not there's a political will, I'm not sure. But we have very strong carers associations and advocacy groups. So you can only hope that things may change.
Thank you, Cathy. And perhaps, hopefully, there are people watching this from all over the world. If you could just say a few words about what the Royal Commission report was, when it was conducted, what was the remit, and who conducted it, just in case people are not
So the
familiar.
Royal Commission was into the Royal Commission ran over a number of years, and it was to look at the aged care quality and safety. And so in the beginning, they were just focusing on aged care, and that was the reason it came about was because of substandard quality of care in residential care. But then obviously you need to look more broadly at the care system, so that we have home care provided in home, and we also have consumer-directed care, or they're called care packages now. And one of the problems with those care packages was that there were really long waiting lists, and so people were being assessed as needing a home care package but weren't receiving it, or being assessed as needing it at a higher level. There are 4 levels, and sometimes there are stories of people dying before they received their care package or the care package that they needed. So the system needed to change, and so that they went around the country and they had submissions and people gave evidence. But one of the good things was that they actually I provided evidence, and they were really interested in looking at care as well, which was good, because carers are part of that aged care system, and a lot of the carers are ageing themselves. So what's happened is that there are many recommendations, and what they're trying to do now is the government has said that they will put more money into the system, but whether or not that is enough, we have to wait and see. So hopefully.
Thank you.
But one of the it was interesting. I was listening to a researcher, Cathy Eager, and she was saying that there was no cap put on profit, and so when you've got a system where you're funded by taxpayers as well as you have profit making, it makes it really difficult to have a balance between high quality care if the motivation is to do with increasing profits.
Yeah, I agree. Yeah. So I see Minna nodding, so I don't know if you'd like to respond to Patrick's question and reflect perhaps on Cathy's comment.
Yeah, thank you. It's interesting how Patrick seems to be interested in values, and I've steering the discussion to that direction. And I think it is very important, and it relates also both to these kind of reforms and existing policies, because we do have some values behind them, even though they are not always so clearly spelled out, but they are there. And also your question relating to this familialism and defamilialization and so on. Of course, concepts should maybe try to be sort of as value-free as possible to grasp the phenomenon. But the policies that they describe, of course, are not. And I think this kind of familialism is not, I mean, we all know that informal care is mainly provided by women. Spousal care is becoming more common by men as well, but at least in Finland. But generally, familialization or familialism means, and refamilialization also means generally increasing role of women in informal care, especially when it's forced. When people do the calculations, for example, in Finland, and this relates also to these kind of reforms, that they are so difficult to make. We have in Finland going on a sort of a family policy reform. They try to change how the parental leaves, the maternity leaves and father's leave and the family leaves are distributed, because they want to have more men taking their leaves. And it is a very difficult process. And women are in a way also blocking that. They say that it's they right as mothers to take that leave. So it's a complicated thing. And I was thinking about this in relation to Nina's presentation. I was thinking that there are at least two things that came to my mind regarding that reform in Germany, and when you compare it to England, is that in Germany the care system is very much relying on third sector, whereas in England it's much more based on profit making. So here comes again this profit as an extra variable to care, like Cathy was kind of bringing out. And also that, I don't know whether, I mean, the gender contract, it comes to my mind, this kind of generational and gender contracts. In Germany, it is really set in the law that children have to care for their parents. But how is it in England? I guess it's not explicitly, at least, set in the legal framework. So the sort of the generational contract is different in these countries, but the gender contract, I don't know how is the female labor force participation in England, but in Germany it has been historically rather low. It's been increasing, but these implicit and explicit values regarding the roles of males and females in the families are rather different, as far as I understand, in England and in Germany. And regarding this Cathy's presentation, I think it was very sort of brave what you have done, because I have always been sort of getting angry when, at least in Finland, when the elder care is in the political and the media discussions, it's always, the discussion is about how expensive it is for the state and for the municipalities. But nobody's saying what does it actually cost for the people themselves. Even though we have public services, which are not so easy to kind of access, but still we have. But they also have user fees, and it's there are lots of people who can't afford even the public services, even if they were able to access them. So I'm really interested in getting your publication, if it's possible. I can send you an email, and I would be interested in getting that. And I think it's also the conference organizers have very nicely put our papers in one session, and so nicely kind of fit together. So thank you for that.
Yeah, I think Minna has uncovered my implicit interest in values there, and my my attempt to move the conversation onto those things. But although I don't think we can come to a conclusion about how to tackle these wicked issues that we all face in the very different systems which we're discussing. I think discussions like this are really, really important to start contributing to the process of building something more sustainable. So thank you so much for your contributions.
Nina, were you going to say something?
Yeah, I mean, I'd love to come back to Minna on some of those points and reflections you made. I think around intergenerational fairness, that's a really interesting one, where I can't imagine us trying to introduce some legislation to say that adults in England are responsible for their parents' care in legal terms, but definitely that debate does crop up in other ways, particularly around housing, which I didn't have time to expand on in my presentation, but there are so many headlines about obviously loss of the family home, and that's seen as it's like a really emotive touch point that is hard to separate from the debate around social care reform here. So how that will play out in future months will be really interesting. And then on your point about defamiliarization, which is a really long word, it makes me think of Japan and how their government actively designed for that. And obviously, see a lot of nods, so you're obviously all aware, but for those in the audience, their government specifically designed to try and actively help women into the labour market, so took a very different approach to Germany. They actually don't offer cash benefits in Japan, so this comes back to values and needing the need vision in terms of what we'd want our social care system to look like, how it affects people, and the need for joined up policy spanning obviously labour market policy, social security, social care, and so on. So thanks, Minna. They're really interesting reflections.
Thank you. Perhaps I can have a question or reflection coming back to Nina's presentation about Germany, and you mentioned the importance of a workforce strategy and migration in fair international recruitment. And we know that Germany has a rather substantial grey market of care that is largely provided by migrant living carers from Central and Eastern Europe. Have you got any kind of reflections on that as opposed to the UK, which up until now has had a fairly limited grey market, either because of the fairly widely available cash for care kind of direct payments that allowed people to employ personal assistants, or because of the marketization, these kind of agency roles were filled by market actors. So I don't know if you could reflect on that, whether that is, yeah. Thank you.
Yeah, thanks, Agnes. That's a really interesting question. I guess, yeah, it's very tricky, I think, thinking about the grey market. There wasn't actually a lot of data that we were able to find. I think actually we heard from some interviewees in Germany that, well, their suspicions were that there's an incentive from the government to pursue more research on that area, because it's it obviously helps to reduce public spending overall. So just gathering my thoughts, because it's such a big issue. I don't think, like how you've described, I don't think there's a risk of a grey market emerging in the same way in England because of the different ways our cash for care systems operate. And obviously we're now experiencing a very new immigration system, which doesn't offer a formal route for care workers from other countries. But I guess what all of this means is that probably we're going to see a much more heavy onus on informal carers, and almost a re-familialisation, if you like, potentially over coming years. And one other thing to note about Germany is that from what we read, there was a sort of emerging trend of people in need of care being actually sent to other countries, sometimes in Eastern Europe, where care is more affordable, and they said that they could have a better quality of life there. But in terms of ethics, what this means for all the countries involved and the workers involved is obviously really questionable. And I guess this comes back to the need for policy which joins up informal care, formal workforce, in a much more holistic and comprehensive way. Because it seems that people are having to find solutions for themselves, and like Cathy described, the costs of that are huge and go unrecognised a lot of the time, at least in England.
Can I say something about this also? And I think exactly what you said now, that people are left to find out by themselves. I think this is this might be sort of a trigger towards this kind of migrant in the family care type And even if the migration system might be strict now, it might not be at other point, for example. So I think we need to sort of think what if. And I think it's also interesting that it's sort of a geopolitical or geographical issue. What Germany are in the middle of the Central Europe, and it has borders to the Eastern European countries where they are able to still, or have been at least so far, able to recruit these care workers. And that's what I've been sometimes wondering, that Finland lies next to Russia. We have a massive, like a very long shared border with Russia. And how much that, why don't we, for example, have Russian live-in carers in Finland? Is it because we have a good service system, or is it more sort of a cultural issue that it would be very difficult for Finnish families to have a Russian carer in their home? We have a long and complicated history with wars, and the relations between Finns and Russians are sort of mixed. There are lots of Russian immigrants in Finland. It's the second biggest migrant group in Finland after Estonians. So there are lots of issues that are at play here. And also, I think what we have in Finland, exactly this informal care allowance, even though the assumption is that there's an existing relationship between the person who needs care and then gives care and then gets this informal care allowance in Finland, you could just as well say that this Russian person, for example, is an old friend, and we apply informal care allowance. Or we could say that the spouse is the actual carer, and then he or she is paying for that Russian person to do the actual care work, because there's no control in how you use that allowance once you get it. You have to make the agreement, but then there's not really any control how you use it. So there are lots of these kind of options that open for live-in migrant care. And if things continue as they are going at the moment, I wouldn't be so surprised whether this is something that will emerge at some point, maybe also in England. It's good to think that what if.
Can I jump in? I think that both of what you're talking about is really important, but we need to underpin the idea of this idea that care workers, care recipients are all connected. And so what we want to do is have good quality care. We want to have good quality work for the care workers, and we also want to have good quality support for carers, and so that they have options to the employment. So you don't want to disadvantage one group, say care workers, and have them working in poor conditions so that the care recipient can have really good high quality care and flexible care. So it's this idea that we want the whole system to work for everybody. And maybe that's very idealistic, but I think it's really important that people have options, but they also have options to enter good quality care, and the workers have good quality working conditions, and the carers have access to the services that they need, so that they can either choose to provide care or work or do both, or have leisure and holidays. So.
Yeah. Patrick, yeah, are you going to say something?
Yeah. I just it was just on. Sorry, I've gone completely blank. But I just wanted to reflect on this this idea of the grey market. I'll come back to what Cathy was saying, but I had in the interviews that I've been doing for my most recent piece of work, which is comparing care regimes in the UK since the devolution of social care policy, which is something that Nuffield were interested in as well. I think this issue of the grey market, Nina suggested that perhaps we don't have a grey market, or that it's very low level in the UK. I don't think we know. I think there are a great deal of people who, pay people with cash in hand to help their parents out around the house, to do domestic tasks, gardening, helping with the washing, food preparation, housework, domestic tasks, and particularly since local authorities in England over the past 15 years have largely excluded any of these tasks from their support. The local authorities don't support people to do these things anymore. So I would be surprised if there hasn't been an uptick in this sort of grey market for domestic tasks. And then I would be surprised in turn that that there wasn't a relationship between those informal domestic arrangements and some elements of personal care as well. So I think it's something that really needs to be looked into, this idea of a grey economy for care in England, but there really is such little data on it. I'm only suggesting these things just from discussions with people who have needs for care and people that work all over the UK. I think it's probably particularly happens around in rural communities in England, where perhaps there aren't access to these more formal services, home care agencies, and access to state services as well. So yeah, I wouldn't be so quick to say that there's not much of a grey economy here in England. I think it probably does exist, but kind of undercover in some way because of the obviously people don't want to talk about it because they're not paying tax or something like that on a cash arrangement that they're making. And just to come back to Cathy's comment about weighing up the different interests of the stakeholders that are in the care system, I think that's a really, really important thing that we have to think about when we're talking about building sustainability in systems. But we have to try and build, if we're talking about building sustainability, we have to build sustainable political institutions which can then deal with that debate and not exclude any of those parties, which we often do when we have these discussions about social care systems. The people that are involved are often advocating for one set of stakeholders, and we often say, care, older people are much worse off than disabled people, or care workers are so much worse off than anyone else, but we need to find a political space to deal with these debates in a way where we can try and share values and find a common good, maybe for social care. That's it.
But I just have a quick comment there that it is interesting that at the time of the elections or before elections, actually all parties have candidates who are very much pro-care and care services and supporting informal carers and so forth. And then when it comes to the actual political agenda, when they are in decision-making bodies, then it's quite different. So in a way, one could think that this is something that it's possible to make a political agreement and consensus decisions related care topics. But of course, then when comes the issue of money, then there are also other interests involved, and then it's again more difficult. So that's how it tends to go.
Yeah, thank you. So we've got about 10 minutes left. Are there any questions or comments to each other before we wrap up? Okay, I don't know. Oh, yeah, sorry.
I'm just going to say I had one very quick reflection, which was that I guess having experience of care yourself makes such a big difference in understanding all the issues that carers face. And I was really pleased actually to see that the leader of the Lib Dems in England, Ed Davey, has put caring at the top of his personal political agenda. And that's, I think, in large part because of his own experience of being a carer. So I wondered whether in Finland and Australia you have any politicians who have taken it upon themselves to really champion that cause, or whether that's quite rare.
We actually have a minister for health and social services whose education is, she's a sort of a assistant nurse by education, but I don't know whether it is because of this COVID situation that she has been quite in the background, because the task related to the pandemic has been given to another minister in this field. So hard to say, but one would think that she knows about these issues. I don't know whether she has been working in the elder care, and we have one member of parliament, Sirpa Pietikäinen, who is she's often promoting that she's an informal carer for her mother, I think. So they are, and there have been some local municipalities where the local politicians have been sort of working in a nursing home for one day or something like that. So there are these examples.
Yeah. In Australia, not so much about elder care. There are a few who have taken leave for childcare, but the elder care issue is not foremost for many of those. Maybe because they have other people doing the care, so it's not so difficult for them. But I'm not sure. Yeah. So, but I do think that people's lived experience does change your perspective on some of these issues, although it shouldn't. But because it's good to be empathetic to everybody's situation. But yeah, hopefully in the future, particularly with some of the findings from, as I said, the Royal Commission, these stories will be more prominent and give people and politicians food for thought. So, but can I ask a question? I mean, sort of going from the very broad to the more general, but I'm really interested in this idea of that generational contract. I mean, I agree, in Australia, we don't have anything like that. I mean, there does seem to be an idea that you will look after your parents if you can, but I'm interested in how people receive that, or how receptive people are to that sort of legislation. Do you know, Nina, in Germany, is that something that people feel that they don't want to do, and what happens if they don't? Are they prosecuted?
That's a really good question. And actually, as part of doing the interviews, when we first learned that childless adults had to pay, I think it's 0.25% more than parents, so people who have children, we were just astounded and just kind of incredulous as to how they managed to pass that. But according to our interviewees, no one batted an eyelid. It was very much with the grain of sort of the norms and expectations. And also as well, if you're an adult with care needs who can't afford to make your insurance premiums yourself, the state will intervene, and there is a means test involved. And as part of that, your children, if you have them, their income and assets are assessed, so they're then obligated to pay on your behalf. But yeah, it's really striking. And another thing the interviewees mentioned was, even though there's that cultural expectation, there is an undercurrent and a shift away from the family providing care, with, I think, a lot of younger people being disgruntled that not only do they have to pay really high taxes, or relatively higher taxes, and are likely to ongoing into the future, they're obligated to look after their parents too. So whether in future years the German government is able to keep them on side, if you like, through encouraging policies and support, is sort of one to watch. Yeah.
Yeah, interesting. Thanks.
Thank you. So I think we could continue this discussion for hours because it's fascinating, and I still have so many questions, but I think we need to kind of wrap it up now because it's nearly time. So I'm just going to open up for a quick round of final reflections if you've got anything to say. Shall we start with Patrick? Sorry.
Just make sure. Yeah, I'm on. I just want to thank everyone, because I just think that it's such an important discussion to have. And although, when I first looked through the presentations, I thought, what's the thing that kind of pulls these presentations together? And I think, there is a genuine, in the wake of COVID, a genuine emphasis on, a genuine want for people to build sustainable care systems, and to both uncover, the injustices which exist within the existing systems, but also to build some consensus about how we can move forward, and build fair and sustainable systems for the future. And I hope this discussion can contribute to some of that.
Thank you. Next, who would like to say something?
I can, of course,
Minna?
just say that. Yeah, I can just say that this discussion at least reveals how important it is that we do international cooperation and comparisons, and that we continue these discussions, since there are so many things that we can learn from different countries, even though the care policies are generally not directly transferable, and making reforms is very, very difficult, especially the bigger ones. But there's lots that we can learn, and also this kind of it's very sort of educational, one could say, to take some concepts and check how they work in different contexts. So this kind of theory testing and maybe theory building as well it's very important for us. So I'm very happy about this conference and this session that we had.
I like to agree with that, but also having the discussion online, I think, shows that it is possible to have meaningful discussion from people around the world, particularly from us from Australia, where it's a very long way to get to Europe and sort of a cost. But I mean, it's really great to be able to bring people from different countries with different perspectives. Although there are differences, I think there are lots of similarities as well, and we can each learn from the other. So thank you.
Thank you. Minna?
Yeah, I'd agree with everything the rest of the panel said, really. And my personal takeaway is, I think we need to do much more, at least in England, in terms of recognising the contribution that carers make and people who are working in any potential grey markets, and having crystal clarity over the contributions and the costs that comes with in terms of thinking about future reform is really important. And I'd like to thank Patrick and Agnes for hosting this discussion.
Thank you very much. So thank you very much, everybody. Really enjoyed the discussion, and hopefully we will receive some questions and then we'll discuss those or come back to those. So, thank you.
Thank you.
Thank you.
Bye-bye.
Thanks.
Bye. I don't know.